break. We'll now begin session 7, titled Cognitive Impairment, Accessible Telehealth in Dementia, which will be a panel discussion led by Dr. Soumya Iyer. Dr. Iyer is a geriatrics physician and the VA's Vision 21 Specialty Clinical Resource Hub Geriatrics Section Chief. Prior to this role, she served as the Associate Director of Clinical Programs at the VA Palo Alto Geriatrics Research, Education, and Clinical Center. She is from Louisville, Kentucky, where she also completed her medical education. She completed her residency in internal medicine at Kaiser Permanente Oakland Medical Center, followed by a master's in public health at University of California, Berkeley, and fellowship training at Stanford University. Her areas of clinical interest include dementia care and telemedicine. Her other areas of interest include designing dementia-friendly healthcare systems and innovative patient-centered care models. And with that, Dr. Iyer, take it away.
Thank you so much, Dr. Poulos, for that introduction. I'm honored to be here today and lead this session on cognitive disability and telehealth. My visual description is I'm an Indian female with black curly hair wearing a green shirt and a white background, and I'll be sharing some slides. So today we're going to cover a lot of material. I'm very excited to be here. We'll be discussing what cognitive disability is. We'll be describing why this is important for this population and why this population really needs telemedicine. We'll be describing challenges and benefits of telemedicine from this population and bringing in the caregiver viewpoint for sure. And we'll describe exciting new developments on the horizon for dementia care and how telemedicine may be used in the future. And we'll certainly end with takeaways so we can make sure that all the information discussed today is clearly communicated. I have an exciting panel of experts and colleagues who will be joining me today, and they'll be introduced as they appear in our presentation today. First, joining me in this first section will be Dr. Christine Gould, a clinical geropsychologist and researcher with the VA, who's also a clinical associate professor of psychiatry and behavioral sciences at Stanford. So let's start at the beginning. What is cognitive disability? It's not one condition, but it can include impairments in a lot of different cognitive domains. So some of these domains include memory. We commonly see things such as short-term memory as a cognitive impairment that's frequently noted, as well as attention, impairments in language. And again, this could be spoken language or written language. It can include how language is communicated, but also how it's received, how people take in information that they hear or see written. It can also include impairments in domains including processing speed, problem solving, reasoning, and planning skills. So a person with a cognitive disability may have one or more of these type of disabilities and impairments in various domains. There's many, many conditions that could include a cognitive disability, and here are a few of them. So traumatic brain injury, or an intellectual disability from childhood, or stroke or dementia. We're going to be talking a lot about dementia in this session today, but it's actually a little bit different than some of these other conditions. So for example, traumatic brain injury or stroke could be one-time major events, after which a person could undergo rehab and actually have some improvement in the condition or the impairments that they have. This is in contrast to dementia, which is a progressive illness and worsens over time. Let's talk more about what dementia is. In the news media, we often get a lot of confusion around terms like Alzheimer's and dementia, but actually dementia is not one disease. It is a syndrome or group of symptoms, an umbrella term really, that describes having cognitive impairments in more than one domain that actually affects how a person functions in their day-to-day life. So that could be something relatively like having difficulty with medication management or finances, Or it could be something really major like needing help with bathing or dressing as some of those basic activities of daily living. So dementia just means that these impairments are to the degree that they affect functioning. It can have lots of different causes. There's lots of different types of dementia. Alzheimer's is the most common type. So 60 to 80% of dementias are thought to be of Alzheimer's type. You've also been seeing again in the news a few cases of actually of frontotemporal dementia being diagnosed in some celebrities in the last few years. There's other conditions such as Lewy body dementia or Parkinson's. There's also dementia related to cerebrovascular disease or having conditions like diabetes and high blood pressure and high cholesterol for lots of years can lead to this type. So lots of different, and there's many more that I didn't mention here today. Dr. Gold, would you like to tell us a little bit more about the prevalence?
Sure. Thanks, Dr. Iyer. And I'm so happy to be here with you all. And my visual description is I'm a white female with curly hair, with a red shirt on, a blue blazer, and in front of a green wall. Dementia, especially Alzheimer's disease, affects so many individuals. Overall, 1 in 9 persons in the United States over the age 65 has Alzheimer's disease. For individuals who are 85 years or older, this increases to 1 in 3 individuals who have Alzheimer's disease. On this slide, we're showing a portion of the 2024 Alzheimer's Association facts and figures. It's showing the prevalence and the number of individuals with dementia, specifically Alzheimer's disease, in various states. For example, in California, where we're at right now, more than 700,000 individuals have Alzheimer's disease. And now let's turn to considering how dementia impacts functioning and how this plays out in the context of telemedicine. As Dr. Iyer mentioned earlier, dementia is progressive. It will start by affecting tasks like medication management, paying the bills, keeping track of appointments, and will gradually increase to things like needing help with the basic tasks of daily living, like bathing, dressing, toileting. So eventually, everyone will need some caregiver assistance. Let's turn to those domains that Dr. Iyer introduced us to and consider the changes in those domains and how that affects the experience of telemedicine for someone with dementia. First, we have memory. So individuals with dementia have more difficulty with short-term memory, and this can make it pretty difficult to answer questions during a video visit from a clinician about things that might be going on in their daily lives. An individual with dementia's attention will be impaired, which can make it more difficult to sustain attention during a video visit compared with a face-to-face visit in an office. Their language could be impaired depending on the type of dementia, and this could affect the person's speaking and/or processing of language, possibly also their reading and writing. Learning also can be impaired, and for many older adults, they may already have lower comfort and less experience with technologies like smartphones and computers. For individuals with dementia, the new learning of these technologies may be even harder. Processing speed could be variably slower. And if someone has sensory changes such as hearing impairment also, the setup and the visit itself could be more difficult for that individual. It might also take them more time to respond to and process the information and what they're being given during a visit. Problem solving, reasoning, and planning are all affected. Thus, keeping track of telemedicine appointments, following login instructions, troubleshooting the apps that need to be downloaded and used, logging into websites, remembering passwords, all can be affected as well. And many individuals with dementia will need some assistance when joining telemedicine visits, and caregivers are an essential partner in delivering telemedicine care. I do want to take a moment, though, and acknowledge that not all persons with dementia have a caregiver or have someone who can help them join a telemedicine visit. The typical caregiver is a spouse or a cohabilitating partner or family member. Many caregivers may be older adults themselves, and have their own health conditions that they have to attend to, in addition to having sensory impairments that may affect their experience of a telemedicine visit. And I'll turn it back over to Dr. Iyer.
So let's talk a little bit about why telemedicine is so important for this population. Truthfully, those with dementia have had a lot of difficulty getting to in-person appointments far before the COVID-19 pandemic. So getting to in-person appointments was hard before the pandemic, and it's certainly true through the pandemic and even afterwards. So we talked to a lot of dementia caregivers of older adults and wanted to learn more about their experience with attending in-person appointments in telemedicine. And here's what they shared with us. They discussed that many of them would wake up hours, like I'm talking 5, 6, 7 hours before an appointment, and leave that much time to get ready because there was so much to do. And what they said was, a lot of tasks have to happen. They have to, wake up, they have to brush their teeth and take a shower, eat something, get ready, get dressed. There's so many steps, and these steps have to happen in sequence. But sometimes their person with dementia didn't share the same goal as them. They didn't either remember that they had a visit, they didn't want to go to a visit, they didn't understand why they had a visit. So for a variety of reasons, it could be really challenging to get through the whole sequence of tasks. They said it was really that routine disruption that added a lot of stress to their day, to the person living with dementia's day. And they had to navigate all of the cognitive, emotional, physical, and behavioral challenges that came along with that routine disruption. Then when it came to actually getting into the car and going to the visit, they said this was definitely more challenging than just having a ride. Some of the caregivers themselves had medical issues that precluded driving, but even if there was a car available, as you can hear, there's just a lot more steps. So a ride is necessary, but not sufficient to get someone with dementia to an appointment. So they talked about the anxiety and stress in traffic could be a lot, with sometimes the behavioral issues resulting. It could be someone grabbing a wheel or trying to get out of a car in that stressful situation that could be really dangerous. Also, just navigating all of, again, in addition to the cognitive issues, the balance, incontinence, cardiovascular, and orthopedic issues. So some of the anecdotes that they shared are, for example, when actually walking out the door, their goal was to lock the door and get in the car safely and drive. And sometimes the person they were caring for might actually see that as an opportunity to leave when the door is open. So they would walk off and not really get into the car. Or there was a lot of issues with falling and incontinence episodes in all of these steps that they had to navigate. So again, getting to appointments can be really challenging. So the role of telemedicine for access to care and helping mitigate this, as well as the cost and all the cost savings and time savings, was just really profound for these caregivers. So next, we're going to have a fantastic speaker, Dr. Natalie Edmonds, share more about the caregiver experience and caregiver perspective. Dr. Natalie Edmonds is a board-certified geropsychologist and founder of Dementia Care Blazers, delivering online health education and information to over 425,000 dementia caregivers weekly. Here's a conversation that I had with Dr. Natalie that I'd like to play for you now.
Hello, in this portion of the presentation, I'd like to focus on the user experience, particularly the voices of family caregivers. We know that in dementia, it declines, which means that every single person who has dementia will at some point require the help of another person to attend telehealth appointments. Many times that other person is going to be a family member, and often that family member is an older adult themselves. It's important to realize that there are many stereotypes about older adults, about how they're fearful to use the internet or that they can't use technology, but it's important to acknowledge many older adults have a desire to learn how to use technology, have the ability to learn to use this technology, and are rapidly using this technology, as we saw during the pandemic. I also see this myself every single day. These are two clips from my two social media accounts between the dates of March 30th, 2024 and April 28th, 2024. We can see that on Instagram alone, of the over 427,000 accounts reached during that time frame, 26.4%, the highest percentage, came from the 65 plus age group. Similarly, on YouTube, again with over 427,000 views during that same time period, the largest segment of the population tuning in was 36.3% with the age group of 65 and older. Many older adults are using the internet just like you and I are using the internet. I leveraged social media and I offered a volunteer survey of experiences family members have had using telehealth appointments for their loved one. We had a response of 479 caregivers during the time the survey was available. Of those 479 responses, 80.8% of caregivers said they had already attended a telehealth appointment for their loved one. 58% of that 80% found that telehealth was just as helpful as an in-person visit, 22% found it less helpful, and 20% found it more helpful. That means the vast majority, 78% of family caregivers, find telehealth services just as helpful or even more helpful than in-person visits. One of the questions I asked on the survey was, what makes a virtual appointment simple and easy for you to use? One of the common themes that came up, about 70% of the responses, had to do with a reduction in anxiety and agitation for their loved one. The Alzheimer's Association predicts that about 90% of people with dementia experience something called behavioral and psychological symptoms of dementia, which means that agitation, restlessness, anxiety, these are very common symptoms that they are experiencing and family members are trying to manage. So the fact that telehealth services can help reduce that is quite a big deal. We saw many comments similar to this. It's challenging with my mother's mobility, in addition to her moments of agitation, to get to her appointments in a timely manner and without stress on her and myself. Attending in-person appointments can be very challenging for family caregivers, as Constance shares.
Well, I would take the day off work, travel 45 minutes to get my mom, get her ready, travel another 45 minutes to the doctor's appointment. She'd have a walker sometimes, a wheelchair the other, and get her in for the appointment and then travel back home. That whole day for a dementia care patient is very difficult.
And not only are telehealth appointments super helpful for the person with dementia, they're incredibly helpful in reducing stress for the caregiver as well.
I've used telehealth for the last year to make her appointments, and it has been such a blessing to me. Having access to telehealth has lessened my anxiety, makes medical care more accessible, and gives my mom the ability to receive care from all of her specialists and communicate with them at the touch of a button. It also allows my mom to have immediate care in the comfort of our home.
She was able to stay in a more comfortable environment at home. We didn't have to deal with safety issues or her disrupting the medical office. I can't drive at times because of my medical condition, so this was no longer an issue.
Another question I asked was if you could make any request to the people who create technology for virtual appointments, what would you ask for? Several notable themes came up. One was to simplify the sign-in process. Very clear instructions for how to join the appointment without needing to download a special software. A simple login or email link that brings you right to the visit. An app that stays on, so all I have to do is press a button at the time of the call. A shorter sign-in. Zoom or FaceTime would be nice. Simple, direct access without extra downloads. Another common theme that presented was anxiety during the wait times and family members wanting to make sure they were in the right virtual room and clicked the right link. Music or video on screen while waiting for nurses and service providers to make their appearances on the visit. Sometimes I can't tell if I'm connected or in the correct place because it's silent or dark, so I just hold on and hope, which actually adds anxiety to the situation. A means for the provider to acknowledge that you are there and the estimated wait time. Something that says you have everything set up for your appointment. Your doctor will be with you in the next 30 minutes. Another theme had to do with tech accessibility, conversations simultaneously captioned, a transcript available right away, automatic subtitles, not everyone speaks clearly, translation services, a written transcript in my email box after the appointment. And finally, another theme was family members wanting to update and give accurate responses about symptoms without their loved one knowing, because many times people with dementia don't understand they have dementia or don't believe they have dementia. So this can be a point of contention. How to send a list of concerns before the appointment that can be addressed during the appointment, and the ability for 2 logins to a call for family members to join, or for a power of attorney to be able to text answers from a phone for the doctor to see privately during the call. If anybody would like access to all of the responses on the form, you're more than welcome to reach out and I'd be happy to share. Thank you. Hello.
Thank you to Dr. Natalie for that. Next, I'd like to share a conversation that I had with Dr. Lauren Moo discussing telemedicine benefits for those with dementia. And our next guest is Dr. Lauren Moo, a cognitive behavioral neurologist at Mass General Hospital and at the Bedford VA, and an associate professor at Harvard Medical School. Thank you for joining us today.
Thanks, Soumya, for inviting me. And hi, folks. I'm going to be talking about some of the benefits of telemedicine for those with dementia. So one of the key benefits is that, similar to old house calls, video visits into the home are really a sort of a virtual home visit. And so you really get to see people in their natural context and get a full sense of them in their sort of social, psychosocial context, and get to see their home. Beyond that sort of holistic view, there's very practical benefits to doing a video visit into the home. One of the key ones is things like pharmacologic management and understanding what medications they are. Typically, in an in-person visit, you're either going through the list of medications in the medical record and saying, are you still taking this? Are you still taking that? And they just say yes, and you're not sure if they really are. You don't know what else they're taking that you're maybe not prescribing or aren't listed in the electronic health record. If you're doing a video visit into the home, you can say, why don't you show me all the medicines that you're taking, or show me how you organize your medications? Or if the person says, oh yeah, I got a new medicine from my cardiologist, and they don't know the name, you can say, why don't you go get the bottle and show me, and have them just hold it right up to the camera and you can read the label. Another real benefit to doing a video visit into the home is that, for me, I find it easier to arrange a time to talk to the caregiver alone, apart from the person with dementia. Often caregivers are not that comfortable describing some of the changes in behavior or abilities that the person with dementia has had since the last visit in front of the person. And so I sometimes will suggest that the caregiver start the video visit with me, separate from the person with dementia, who might be in the next room watching TV in the recliner, and then they go get them and have them join us later. That gives them an opportunity to tell me about, say, wandering or agitation or violent behavior or something like that that they might not feel comfortable talking about in front of them. In general, there's just less routine disruption, and less routine disruption for both the patient and the caregiver. And that means that because they didn't have to wake up extra early, because they didn't have to skip their usual visit from their home health aide and so on to come to the visit, they are more comfortable, they're more relaxed, and you're getting to really see what they're like in their normal context, not physically only, but also emotionally and behaviorally. Those all contribute to some of the benefits of not having to come in person to a clinic visit that go beyond just avoiding traveling, saving time and travel, which of course are huge, but also some of the sort of rearrangements and logistics that a lot of families have to engage in to come to an in-person visit, such as canceling that day's daycare, arranging for the Wheels on Meals delivery to be on hold that day, etc. So I have been doing video visits for dementia for over a decade now, and I have to say that, to me, there's just so many benefits and many instances where I have learned things that I would not have learned otherwise if I'd only done in-person visits. For example, I had a patient that I'd been following in clinic for a number of years who's always brought in by his son, but his son was not his primary caregiver. The reason the son came is that that was the main mode of transportation for that caregiver and patient with dementia. The primary caregiver was the man's spouse, but she was a wheelchair user, and so it was difficult for her to get in the son's car with the veteran as well and come into clinic. So by doing a video visit, suddenly I was able to meet with his primary caregiver and learn about her experience and her reflections on how the patient was doing. I've had patients, back to the medication thing, who I've learned when I've asked them to show me their medications, they've showed me all sorts of supplements and over-the-counter things that were somewhat questionable sometimes that I had no idea that they were taking, and I really would not have known without doing this sort of virtual home visit format. I've had a patient who had some language problems and really had difficulty articulating things, but was in a day program where he was doing a painting class. And when I asked about it, he jumped right up, wandered off. I wasn't sure where he was going, and he came back and held up to this camera this painting that he had done, and he was incredibly proud. And it was interesting for me to see his skill at painting, which was a new skill. He had not been a painter before. So I would not have learned about that if they just told me about it in clinic. I've also learned about who's in the household. For example, I've had patients where I did not know that they were primary afternoon babysitters for a number of grandchildren. I saw toys in the home or seen children in the background. I did not realize that that was the household makeup, and that really sort of changed my perspective on the social and family context of those patients. Sadly, I'm also currently a caregiver myself, and I will say, despite this being sort of a passion of mine and my having done dementia video visits to home for over a decade, when my own father was offered by the doctor, hey, do you want to do the next visit as a video visit, he immediately said no. The way it was offered, I think, is part of it. There was no emphasis on some of the benefits of it being a video visit, and they didn't really offer it to us together. They offered it to him. And so I was not able to chime in, and I sort of went with it. I think part of that also is sort of the flip side of this is my father looks pretty good when I bring him to clinic, but he has a very cluttered home that I think he's somewhat embarrassed about. I think that for me, a video visit would be much, much more convenient. And in fact, allowing his clinicians to see the clutter in his home rather than my having to hint at it in front of him would probably help me get the clinicians to see the real situation of what's going on in my father's apartment and perhaps benefit me as a caregiver in that way as well. So doing video visits into the home, I would argue, is highly beneficial for patients, for their caregivers, and for the clinicians who take care of them in terms of getting a more holistic view of what's going on. But it does take extra planning, and it does take extra work from a technology and scheduling point of view. And I think that that's the direction we need to go, into reducing those pain points so that doing video visits are easier for everyone. Thanks.
Thank you to Dr. Moo for that. So there's really been a lot in the news in the last few years about new Alzheimer's drugs, and I wanted to bring a clinician and researcher really on the forefront of all of these developments. So here's a conversation I had with Dr. Sharon Shaw. I'm happy to have Dr. Sharon Shaw, a clinical professor of neurology at Stanford University and the chief for the Memory Disorders Division, and a director of the Huntington's Disease and Lewy Body Disease Centers of Excellence, here with me today. She's also been featured in international media and documentaries such as BBC How to Stay Young and the docuseries Limitless with Chris Hemsworth. Thank you so much for joining us today, Dr. Shaw.
Happy to be here. Thanks for including me.
Of course. I wanted to chat a little bit about future of dementia care a little bit. So there's been a lot in the news lately about the new drugs for Alzheimer's. Can you tell us a little bit about what's on the horizon for dementia care?
It's really exciting, and we're at an inflection point with treatments for Alzheimer's disease and hopefully other diseases that we're facing. So what was approved last year was an antibody that targets amyloid, and that is one of the proteins that builds up in people who have Alzheimer's disease. What a lot of people don't know is that this protein builds up in the brain 15 to 20 years before people even start to manifest clinical symptoms like memory loss and others. So this drug right now is approved for people who have mild cognitive impairment and mild dementia for Alzheimer's disease. But we might learn in a few years whether this drug also works to help prevent the onset of memory loss. We expect that other drugs similar to this mechanism may be approved in this year or following. So that's really exciting. But I want to temper a little bit of the excitement in that these medications require infusions. It does require people coming in frequently for those infusions, and they have a lot more side effects than we've seen with the other drugs that we use for treatment right now. And because of those limitations, there's still a lot of push and interest in finding other therapies like oral drugs and other mechanisms that may actually help or work conjunctly with these medications to delay decline. Really, really exciting time.
Thank you. Given all the new monitoring and assessments that are going to be needed to deliver these complex new drugs, these new treatments, what role could you foresee telemedicine playing in bringing this care to patients with dementia?
Yeah, I think what we've really seen through the pandemic is providing access to be seen, diagnosed, treated continuously for people with cognitive impairment. In my practice, I've been able to see patients for longer, more advanced disease who didn't typically come to my clinic because of limitations of physical or distance. So right now, we're already seeing the access increase. For providing these types of therapies to others, we can do those assessments remotely, which can be very helpful for people who live at a distance. There are still continuing to be some limitations because it does require imaging like MRI or PET scan, lumbar puncture, labs. But we're starting to really think about opportunities for access. So if we have mobile labs or mobile imaging, that could really facilitate it, or we partner with other communities to provide these treatments. And we're doing a lot more progress in research for biomarker testing. What I mean by biomarker testing is these biological markers looking for amyloid and tau, those that we see in Alzheimer's disease, but other markers that we see in Lewy body disease and Parkinson's disease. We're looking at blood tests and skin biopsies and other imaging markers that can really help diagnose early. So it's really exciting that we can do a lot of these, but there's still a long ways to go.
Thank you. Fantastic. So we'll continue with some of our key takeaways from our presentation. I think it's really helpful to think of things in terms of clinician level strategies we can use to help those with cognitive disability on telemedicine, clinic and healthcare level strategies, policy and population level strategies. And again, you heard a lot of caregiver input, kind of a technology wish list on what we wish telemedicine would be for supporting this population. So discussing clinician level strategies, I do a lot of clinical telemedicine for older adults with dementia in particular, and use a lot of these. But as you heard from some of our other experts, it's really important to get the caregiver input. When you're taking care of people with dementia, it's a dyad. You have the patient and the caregiver, both of whose input is extremely important in understanding what's really going on at home and helping to problem solve. So some examples of ways to mitigate this are asking schedulers to instruct the caregiver to speak to the clinician first, so there is that private time, or setting expectations that both the patient and the caregiver will get to speak to the clinician just to make sure care is holistically provided. You can also use things like screen sharing. So for example, some people with cognitive disability may actually do better with some visual input along with auditory input. So sharing pictures or graphics that you're explaining can be helpful. Using teach back, that when you are giving some instructions, asking that person to say back to you what they understood can be really helpful to understand and check back that learning is occurring, as well as mailing or emailing out an after visit summary or transcript would be really helpful. As far as clinic and healthcare system level interventions and strategies that can be helpful, having a team or schedulers to practice video visits in advance of an appointment can really help a lot of people, especially if they're less familiar with the technology. Having a telephone help desk for tech support for video visits can be very helpful. Not just a chat feature in an app, especially what they're having trouble with is that app. So some way to actually call in a telephone and get tech support can be beneficial, as well as the direct phone number to reach clinics. I'm sure all of us have been stuck on a phone tree at some point. Press 1 for this or press 2 for that. That can be really challenging for those with cognitive disability. So very helpful to have a direct phone number to reach a live person. As far as policy and population level strategies, a lot of times we're talking about older adults who have limited and fixed incomes. And so programs, they might not have access to these devices. There is, in fact, a digital divide. So reduced cost internet and device programs. Again, there's a few of these that exist out there. They're limited, but I think this type of intervention really makes a very big difference to allow people the technology to even be able to participate in telemedicine, as well as public access spaces for secure telehealth. Again, I've heard of these in very limited pilots, but I think there's a potential to leverage libraries, senior centers, community centers, other safe community spaces where people can go if they don't have their own personal devices, where they could go and use the internet and the device there to be able to use telemedicine. Additionally, there's been a lot of changes in telehealth policy after the COVID-19 public health emergency ended. And again, we do know that state and federal policies are always changing, but there are some changes that have benefited the population. I think especially when it comes to mental health and behavioral health, the ability to receive care in the home without geographical restriction of where the clinicians are, so even potentially across state lines, and being able to have telephone visits or audio only visits are all actually changes that happen in this COVID era that have been really positive for this population. And some policies are actually only temporarily extended until December 31st, 2024, and we'll have to see what happens. But those policies are, for example, receiving telehealth services in the home or video visits. So I think, at a large level, just realizing that we need policy to support those with cognitive disability, those with dementia, to really get medical and mental health care access in their home. So telehealth to the home through video or phone. And if they don't have those specialists locally, or if they're really far away or hard to find, hard to access, being able to get that care from whatever specialist they can, wherever that specialist is located, can be really beneficial. And if we were to make a wish list of what kind of telemedicine we would like that would support this population, I think it's important to remember that cognitive disability is often found in conjunction with other disabilities, so like hearing and vision loss, so not in isolation. So accommodation options are helpful, things like being able to see a written transcript of a discussion, and it's something that you could turn on or off depending on the needs of that individual, the ability to enlarge font or picture, or the ability to hide non-essential information on the screen to make it as close to in-person communication as possible would all be really helpful. Also, we have to remember that older caregivers are an important user base for telemedicine technology, and they may or may not have prior tech literacy. But utilizing design thinking practices, testing new technology with an older adult user base is very important. They're not just theoretically using older adults. There's often you wonder, are they able to use this technology? They are. The older adults do use technology frequently, but it needs to be easy. Additionally, although computer and tablet access are certainly preferred for telemedicine, given the larger screen, you do have to have Wi-Fi to make this work. And again, not everyone has that access. So smartphones are the predominantly used and accessible technology for most older adults. So making sure that all of our telemedicine platforms work seamlessly on smartphones with the ability to call on the phone for tech support and bypass app downloads is very helpful. And so I think our takeaway here is telemedicine for those with cognitive disability needs to be as close to one click as possible. We heard that from so many users that we spoke to for our presentation today. I hope this was helpful. We thank you so much for joining us for this presentation today. If you have any further questions, you're welcome to email me. And I also have some of our panelists here today for a few minutes of questions. Myself, Dr. Christine Gould, and Dr. Sharon Shaw are on the line and happy to take your questions. Thank you.
There was just a comment about how phone trees are challenging for all sorts of individuals, including those without cognitive issues.
Very true. I think a lot of these suggestions and practical solutions that we had that would be particularly great for those with cognitive disability would also just be good care and easily accessible for all.
I think we had a little I'm out here in the backyard thinking Malathi was going to be moderating the questions, but I suppose not. It's a lot of great comments about how awesome this session has been for a lot of people. I'm wondering if what new developments you see on the future in dementia care, any new technologies or other advancements that would be helpful.
Sure, Dr. Shaw, would you like to comment on that? And then we actually got two other questions.
Yeah, we highlighted some of this in the video, and I should say this is Sharon Shaw. I'm from Stanford. I'm 5 feet tall, but you can't see that on video. And I like to think that I carry myself with larger than life stature, dark wavy hair, but graying. So there are a lot of technologies that are advancing in real time, actually. So what we mentioned was biomarkers, meaning that we can do blood tests now to help diagnose one of the proteins that we see in Alzheimer's disease specifically. We can do skin biopsies, along with some of the older methods of imaging with MRI and PET scans and spinal fluid. So that's really advancing. So if you can imagine, we can do some of these diagnostic markers in the blood, then the access is more available widely because a lot of people can provide blood and not necessarily in an academic setting or specialized setting, but lab vans and things like that can facilitate. And then we're looking more at sort of passive data like wearable devices, whether it's watches or phones that can collect cognitive data, mobility data, all of that information that can contribute to understanding someone's sort of brain health, so to speak.
Thank you. We have some other questions on how do we avoid the overuse of telemedicine with seniors? Oftentimes we miss things. Would anyone like to take this?
I'm happy to comment a little bit too. It's Sharon Shaw yet again, this larger than life stature that chimes in a little too much. Yeah, I think when someone has cognitive impairment, there may be limited insight in being able to provide a full history of what that person is going through. So really taking the time to offer and invite other information from family members or people that know the person well. And it can be a little difficult in a virtual environment to allow for an open discussion with subtle cues that can provide less sort of antagonism. Because as I mentioned, the insight may not be there. People can get defensive if they feel like they're being attacked. So whether it's private conversation or just allowing the opportunity for myself and my patients and family members who are present, I often say jokingly, you know, if I forget, I may not remember that I forgot. So we're just trying to collect all the information here so that we can have as much data as we can.
Yeah.
I'll just chime in a little bit, which I don't think there's much evidence of overuse of telehealth with the older population, especially with dementia. If anything, as I sort of shared with you, I think it's the opposite. We're actually doing a study right now looking at potential ageism in regarding the offer of telehealth to older adults in general, because I think people make an assumption that they can't use it, and so they don't even bother to offer, or they offer it in a sort of lukewarm fashion. So I think I don't welcome there being overuse, but I would be surprised if there was overuse.
Certainly, thank you. And I think as with all clinical care, you have to use judgment depending on the reason for a visit, what would be the appropriate setting, but also the access to specialists and the reality of the patient's situation. Can they get to a visit are all needed to be taken into consideration. Another question is any suggestions on how to provide visual instruction that is not written? For example, demonstrating a task needed at home. That's a fantastic question. And I think it's important to realize that there's a lot of types of cognitive impairment and people taking in and learning information in different ways. So certainly some people might need to see tasks demonstrated, right? And that can be more effective than written, or tasks broken down into their subparts. A complex task perhaps made into a checklist can be really useful for helping people to gain instruction. Go ahead.
I just wanted to emphasize that just this past week, we had a caregiver who was having trouble getting their loved one in and out of the car. And so what we ended up doing was finding a YouTube video from a well-known source, an occupational therapist, who does dementia care, and reviewed the video and then shared it with them to really demonstrate other ways to help them with that task.
Thank you for that. That's a great point. Another question is global across speakers and for those with disabilities. Effective care provision and enough time during telehealth appointments. Medical appointments with physicians, healthcare professionals, rehab have productivity expectations and time restraints. Any suggestions? That is a very good question and a very real problem. Any comments from my panel?
I have a comment, which is I've heard some people make an argument that telehealth is a benefit to healthcare systems because more visits can be crammed in to the same amount of time, not acknowledging that there are these extra requirements, including often having to do a little tech troubleshooting to get people onto a video call. And so I just would sort of caution against that, that I think that that's the way the wind is blowing, and that sort of push to thinking this will increase productivity, when I don't think that that's necessarily true.
I was
Another
only going to say that Sharon Shaw here again, that policy that can really help support allowing the time that's required. We can imagine that someone who has cognitive impairment, we need to gather information from multiple parties, as I had just said. Those who have other difficulties, we need that extra time. People who have language differences than ours, and we need interpretation. All of that requires extra time, and we need the policies changed so to provide that, because we can't give adequate, sufficient, and superb care without the time that's required.
Absolutely, thank you. Another question is it possible that the medication you mentioned for Alzheimer's would also be effective for autism, given we have also observed amyloid plaques in persons with autism?
Tough question. I think what we know about Alzheimer's disease specifically is that the amyloid protein builds up 15 to 20 years before people have clinical symptoms. But additionally, there's the tau protein. So just targeting one of those multiple layers is insufficient to sort of really attack the disease in the way we want to. It's a first step. Unfortunately, my expertise is not in autism, so I don't know the prevalence of amyloid in autism, but it may be worth looking into with a research study.
Thank you. Very good information. Are mental conditions such as depression and bipolar considered cognitive disabilities since they may impair daily functioning?
That's a great question. This is Christine Gould speaking. I think it depends, and they can co-occur with cognitive changes, and they can cognitive changes that are responsive to interventions, and also can increase the risk, depression in particular, over the course of lifetime for cognitive changes.
Touching on memory, processing speeds, planning, and attention reminds me a lot of what I experience as an autistic ADHD neurodivergent individual, and I am excited to hear about all the conversations happening around making telemedicines more accessible for folks with cognitive disabilities. Thank you for your comment. We appreciate and share your enthusiasm with this. How is the reimbursement generally for a video or phone visit compared to clinic visits? Thank you.
Lauren Moo, I'll just say that some of us here work in the VA where the issue of reimbursement is different, but outside the VA, during the pandemic, there was parity for video and in-person visits, and we could get reimbursed for phone visits as well. You are no longer, and we're back to sort of pre-pandemic situation where phone calls with a clinician are not reimbursed. So there's real pressure to do a in-person or a video visit. And I think that also leads to some people's, some clinicians' reluctance to do video visits, because if the video visit doesn't work and you need to still see the patient, usually we will convert that to a phone call, which then is not billable.
Thank you for that. We're actually having great engagement, Dr. Poulos and Dr. Srinivasan. I see several more questions on here, but I think we're at time. Is that right?
Yeah, we're at time.
Wonderful. Well, thank you so much for the fantastic questions and engagement with this topic. Feel free to email if you have any further questions. Thank you.
Thanks very much to all of you and to the caregivers and patients that you highlighted. That was very kind of them to share their time. And I'm going to pass it off to Dr. Srinivasan, who's going to introduce the next session.
Great. And again, thank you everyone so much. What a lively and stimulating conversation.